On that note,
On that note, we shall begin our discussion on. So today we're just going to do the blood and the heart. And then
Mhm.
on Saturday, we'll do the blood vessels and the lymph.
Okay.
Okay. So we'll start kind of cool today, which is straight to the point.
Mhm.
We'll do talk about blood, heart, and then do a little bit of practice question, and then we'll do a final review.
Mhm.
Okay, and then, so now just beginning our situation here, let's talk about, let's do an introduction into the cardiovascular system. The first thing you have to know is that the cardiovascular circulatory system is going to be, has components, and it's divided into your blood, your heart, and blood vessels. We'll learn a lot more about blood vessels on Saturday, but our blood and heart will focus more here during our discussion today. Your blood is going to is it's fluid connective tissue, right? Remember that blood is really important in terms of carrying nutrient gases. We talked about this in endocrine, right? Your endocrine hormones has to travel to the blood to reach its target organs, right? So the blood is very important in that case, and in your heart is also very important, right? Because it's going to pump or push blood around your body systemically and through your pulmonary circuit, right? And your blood vessels are just the tubes that kind of help you regulate blood all around the body, right? And you have different types of blood vessels that are around your body. You have your arteries, your veins, and your capillaries. And, we'll talk a lot about this on Saturday in terms of like, how do our blood regulate our blood pressure, right? The blood that we have, the fluid connective tissue that carries all these nutrients and gases and waste throughout our body. How do we regulate that? Why do someone have high blood pressure or low blood pressure? What is the role of our capillaries, our veins, and our arteries in making sure that our blood knows to go forward, to go backwards, and to just make sure that it's going to the right places, right? This is why some of our blood are kind of got induced or stimulated by, when it constricts and vasodilate, right? When it's constriction, that means that less blood needs to go there, right? And if it's too constricted, what does that mean? That means that it's possible that they may get ischemia or they won't get blood supply to some organ, right? If they vasodilate, meaning they open up a lot more, they open up a lot more of the diameter of that blood vessel. That means that that organ is getting a lot more blood, a lot more nutrient, and etc., right? So that's why the blood vessels specifically are important in terms of making sure that blood is being regulated and kind of pushed throughout your systemic circuit. Does that make sense?
Mhm.
Okay. And then, I mean, we talked about it kind of a little bit already, how your blood is this connective tissue that's carrying all these nutrients and gases, right? But the main basic function really is, right? It's going to carry your oxygen, right? And that oxygen is going to be carried in your red blood cell. We'll learn a lot more about red blood cells today and kind of the components of your red blood cells, right? But essentially, that red blood cell's job is to distribute, right? It's to deliver oxygen to your tissues, right? To unload all those oxygen so that your tissues can get its nutrients, can get be able to survive, right? Take the waste products from there, receive hormones if it needs to receive hormones. Like we said, certain types of organs have hormone functions, like your adrenal glands, right? We talked about that. And then also heat to and from different parts of the body, right? And then another thing that your blood is, and we'll learn a lot about that too today, other than the fact that you're doing a lot of distribution of nutrient, is that you also have different types of blood cells that is going to be involved in fighting against infection.
Mhm.
Okay. Okay. All right. So before we learn about all the cool stuff about blood today, we're going to talk about the blood composition, right? And this is really important, often ignored because why should we know, right? But one of my very, very, very favorite doctor that I admire, I don't even know. I like, this is my, like, I love this dude. Dr. Charles Drew, you know, he invented the ability to be able to transfuse blood. He's the, you know, the first African American person to be able to do that. He was a surgeon, and his research was mainly understanding the composition of blood, the one that we're talking about right now, right? So your whole blood is just this entire thing. Your whole blood, it has your plasma, has your white blood cells and your red blood cells. That's just that. That's what it means when they're talking about whole blood. It's just unaltered composition of blood. Now, there's two basic compositions of blood that you're probably going to get tested on, right? Blood plasma is 55% of whole blood, and then 41% of that is going to be your formed elements, right? In your blood plasma, we'll learn a lot more about the components of your blood plasma, but usually that's going to be like your albumin, you know, your protein in your plasma, and we'll learn more about like why albumins are important. They're specifically important for, like, you know, water regulation, when we're talking about like where water is going in the different compartments of the cell, whether it's going out or in and things like that. It's going to be because inside of the plasma, we have proteins, specifically albumin, that are important for osmotic regulation. And when I say osmotic regulation, let me kind of bring that home for you. Sometimes people get sick, right? People that drink too much alcohol damage their liver, and plasma or specifically albumin begin to exit out of their liver and just exist in plasma. And so they have edema, right? Water starts to follow protein because they kind of like create this osmotic gradient where, you know, remember we talked about, I think it was sometime last week where we said that sodium follow water because they have this osmotic gradient. The same thing happens with albumin, as the proteins in the blood, right? If they exit certain parts of the organ and they now exist in, you know, outside of the vessel, they're going to, the water is going to follow that. And so patients can present with edema and things like that. Specifically, you know, an example of that is like patients that have liver damage, right? Plasma is going to exist outside of their blood vessel. So that's why, I know, it's important to kind of learn like these compositions of blood to understand where specifically kind of the components of them exist, so that we can follow them and figure out when there's disease processes going on, right? So for plasma, that's important. 55% of our blood components is plasma, and then 41% is going to be your formed elements. And your formed elements is just going to be like your 99% of your formed element is going to be your red blood cells. And that says a lot by itself already, right? Why is red blood cells such a big component of the formed elements, right? It's a big component because, one, red blood cells is delivering oxygen to our body. We need oxygen to survive, right? And one thing that we'll learn today is that red blood cells have these heme groups inside of them that carries oxygen, right? So red blood cells is a big component of this formed element, specifically because of their function, right? And then you also have this like a little bit of buffy coat, which is basically going to have your white blood cells and your platelets. And your white blood cells are going to have something we call granulocytes and agranulocytes. And we'll learn a lot more about like why those are important. Yes, they have a very important function in terms of regulating infection in our body, right? So those are just kind of, you know, quick information about the composition of our blood. And then we talked about the, you know, once we said the two basic components, the plasma and the formed elements, we said that the plasma, you can break down plasma even more, right? We said albumin is part of plasma proteins, right? That's important. We talked about that because osmotic and water movement regulation. I think we talked about this like in the very beginning of our sessions before, where I kind of talked about ECF and ICF, right?
Mhm.
Right, and when I say, when you put, for example, if if we say that this is plasma protein, right, that means it's weighing on the water and it's kind of pushing the water out, right.
Mhm.
So that's what I'm saying. It's too much. Like when you put solutes or something that is formed inside of a fluid, that water is gonna want to go where it needs, because it's essentially what's happening is that there's going to be less water inside of here, right? Because there's too
Mhm.
much plasma proteins in it. And because that is the case, water is going to be like, we need to go there.
Mhm.
Okay, so that's what albumin does. That's what sodium does. There's other parts of plasma proteins that is really important. You have your globulins, and your globulins, we'll learn a lot more about that too. We'll talk about the ABO system, the blood groups, and RH and RH negative blood groups. And that basically just talks more into like the different antibodies and immunoglobulins that exist in our body, and how the different cells, like for example, our agranulocytes, our B cells, turn into plasma cells to get involved in secreting antibodies that we need to fight off infection. And then
Mhm.
fibrinogen, fibrinogen pretty much is involved more in terms of like regulating, if you're bleeding, right, your platelets are going to come in and they're going to try to block that so that you don't bleed out, right? So that's why people regulate like how fast are your platelets aggregating. If your platelets are not aggregating fast enough, that means that you have problems being able to regulate bleeding, right? And
Mhm.
fibrinogen is really important in that process. So that's why plasma is important, because one, you can already tell, not only is it involved in osmotic pressure regulation and water movement, fluid movement, it's involved in our antibodies, and our antibodies are important for fighting our infection. And then it's also involved in being able to make sure that we don't bleed out, right? So just your plasma,
Yeah.
55%, majority of your whole blood, which already has like significant function in terms of just your basic function of your blood.
Yeah, I know. When I worked in the lab, I definitely noticed people or the patients who would come in who had like Coumadin in their system. We're
Mhm.
testing their like levels. I'm over here like, sheesh, it's like so thin, it's not
Yeah,
clotting as much.
yeah, and you can really tell, when someone has like issues with regulating, their blood, whether it's because you can see bruises in their
Oh,
skin, things
yeah,
like that.
definitely. Even just drawing their blood off the back, I'm like, sheesh, like this doesn't look good already. But yeah, bruises, you can see it all over their hands.
Exactly. So that's why this is important. I'm just, I'm hoping that, I can make all these connections for you about like all of this, though seen like it's all separate components of our body, they're all very connected. Um, and then other solutes are just, different things that are kind of that not completely unimportant, right? Because we need sodium and we need potassium, we need calcium, right? Those are important for our what we talked about in the last couple of weeks. We talked about, our neurons and depolarization and hyperpolarization and contraction. And those are electrolytes that are important for so many, other functions in our body, right? So those organic nutrients, our glucose, our fatty acids, our amino acid, our electrolyte ions are important for water regulation and or neuron depolarization are heart cells, right? And then organ waste regulation, which is in our kidney. Once we start learning more about kidney and we start to talk about, our the anatomy of the kidney and the different parts of the kidney that it's involved in, urea and creatinine kinase and ammonium, things like that. I'll make sure that we make those connections as well when we start talking about the renal part of anatomy. But right now, just know that other solutes is just going to involve like all these other things: glucose, fatty acids, sodium, potassium, calcium, urea, creatinine kinase, ammonia, all these different things. But mainly, know that albumins are 60% of that plasma of our plasma composition, which is a lot more than all the other parts. So that just tells you more about how important our plasma proteins or those albumins are. So now we talk about the different part of our formed elements, right? We said that our formed elements is going to have 99% red blood cells. In other words, erythrocytes. Know those different kind of namings, right? Because sometimes they just don't say red blood cells, they'll say erythrocytes. Our normal blood cells in our body is usually between 4 to 58 million cells in cubic meter. Like I said earlier, basic function and most important function is being able to carry oxygen in the blood, right? They also regulate some carbon dioxide, right? And this is just going to really be involved in like our breathing process, right? When we inhale oxygen and exhale carbon dioxide, right? So our red blood cell is going to have this biconcave shape. And why is that? Because our red blood cells does not have a nucleus, right? They do not have a mitochondria either. So they depend mainly on glucose to survive. So those are important testing points as well. They like to test that, that they don't have a mitochondria, that they are anucleated, and they do not have a mitochondria. Does that make sense?
Mm-hmm.
Okay, I hope this is helping a lot. Okay, so now another thing about erythrocyte, red blood cell, that is so important is that within our red blood cell, you have this thing called hemoglobin, right? And we have 4 of them. We have 4 different hemoglobins here. You see here, and they're kind of separated between 4 proteins or 4 bound proteins or 4 subunit, right? And those subunits
Mm-hmm.
is going to be 2 alpha chains and 2 beta chains, right? And within each of these chains, they have each alpha chains and each beta chain is going to have this heme group, right? And within this heme group, there's going to be these components. They're going to have these porphyrin ring, which is going to be made from vitamin B12, which is important. If you're deficient in vitamin B12, what happens, right? You get issues with forming your red blood cells. You can get anemia from that, right? B12 deficiency, right? Iron is also a part of that, right? When someone is iron deficient, you can get anemia because iron is an important part of the component of your red blood cell, right? And that's very real. We'd heard about that, right? People that have iron
Mm-hmm.
deficiency, sometimes they eat ice out of nowhere. They just like to eat ice. If you see your
Mm-hmm.
friend eating ice, and be like, look, hey, you might want to start taking iron pills.
Mm-hmm.
And so within these alpha chains and beta chains, what's important to know is that each of these chains is going to have 4 oxygen binding site on each hemoglobin protein, right? So that's a lot, right? So our red blood cell is busy.
Mm-hmm.
One, when I think about oxygen, I think about a car with 4 seats in it. And your job is to make sure they're all filled up.
Mm-hmm.
Deliver them safe to their destination like Uber.
Right.
Okay, so now we're going to talk about, like, now that we talked about, our red blood cells and their important function, now we're going to talk about this ABO blood group, right? This ABO blood group can be a little complicated sometimes, right? But really what they're trying to say to you is that, your red blood cells, this different blood group is going to be based on the antigens that they express on the surface of this red blood cell, right? And if red blood cells with the wrong antigen on the surface are transfused into like a person, right? Your system, your immune system is going to recognize that. And these red blood cells are going to think it is foreign, and they're going to attack that, right? And I'll explain that more. I have a picture that's going to kind of explain this a lot more. And that immune response, when our body reacts or starts to attack, is usually called like rejection, right? And rejection is very popular in like the transplant world, right? Or not just even transplant, but just like transfusion world, right? And so essentially what you want to know here is just the antigen, right, is really important. When we're talking about an antigen, what is an antigen, right? Right? It's really anything that can cause an immune response, right? And usually that's going to sit on like your red blood cell at the top, the very top of your red blood cell. And I'll show you a picture of that. And your two major blood groups is going to be your ABO system. Like you have patients that are going to have blood type A, blood type B, or AB, and type O, right? And then you also have the RH system, and the RH system is going to be like RH positive or negative patients, right? And sometimes when patients, I'll talk about a disease here where, patients that are pregnant that might be RH positive mothers can have RH negative babies. And because they're RH negative babies, they have the antibodies, right? And they will begin to attack they begin to attack the fetus, right? So,
I didn't know that until I started getting tested for it. I was like, oh, I'm glad I don't have it, but I didn't even know that was a thing.
Yes, so it can happen both in the RH system situation, or it can happen in the ABO system as well, especially when you're O blood type, because your O blood type has IgG antibodies, and IgG antibodies can cross the placenta.
Oh wow, I didn't know that. I'm an O.
Oh wow, see, it could have been that too. So here is the deal, right? So you have this ABO system, right? So let's say that someone is in group A, right? And we say that someone that is in group A is considered type A blood type, right? So that means that these red blood cells here, they're going to express a carbohydrate on the surface of their red blood cell, and that's specifically going to be a antigen, right? It is going to be an antigen that's going to hang out on top of their cell like this. There's an A antigen, and antigen is just it's a carbohydrate just kind of sticking up there, right? It's like it's kind of like a costume. It's like, hey, I'm A. Hello, I'm A, and I have this thing on top of my forehead. I am A. And so patients that have type A blood and have those type A antigen hanging out in their surface, they're going to have antibodies, right? They're going to have antibodies that's going to be anti-B antibodies. They're going to have an anti-B antibodies, right, in their plasma. So the deal is your body's going to produce antibodies against antigens that are foreign to them, right? So you don't want your body to produce antigens that are anti-A when you have an A antigen, right? You want your body to produce an antibody that is going to be foreign to your antigen, right? And in this
Mhm.
case, because the patient has a type A blood type, they're going to produce an anti-B antibody that is foreign to that patient, right? So the blood type A has no B antigen, right? Because they
Mhm.
have an
That's
A,
correct.
right? So
Mhm.
because they have no B antigen that is foreign to them, right? So anti-B antibodies is going to specifically bind to B antigen and cause clumping of red blood cells, right, with B
Mhm.
antigen and cause agglutination in patients that, for if for some reason they have, and the thing about this is it could be like, okay, for type A, right? Let's say we have this patient who's a type A antigen, right? They have
Mhm.
anti-B antibodies, and then for some reason, they could have a antigen B that's not even in the surface of the freaking red blood cell. It could just be hanging out. It could be just there, right? And your antibodies, your anti-B
Mhm.
antibodies are going to find that and attack it, right?
Mhm.
The way that they do that is going to they're going to clump, right? And then once they clump, you have your cells that are going to come and kill that. So your anti-B antibodies just means that it's made to attack B. So it is a defense against B. Okay, does that make sense?
Yeah, no, that makes sense.
Okay, all right. So these patients, they can receive blood from type A and type O, right? But they
Mhm.
cannot receive type B because they have antibodies for B, right?
Mhm.
Right. So because they have A antigen in the surface, they can only donate to blood types that do not produce anti-A antibodies, right? So
Mhm.
that's AB blood groups, right?
Mhm.
Right. So okay. I think they usually like to ask questions like that because it can be very confusing. So type A group can receive blood from type A and O, but they can donate to type A, right? And AB.
Mhm. Yeah, that makes sense.
Okay. All right. And pretty much everything that I said for type A is going to apply to the other different groups, right? In this case, it's just
Mhm.
going to be group B is going to have an antibody that is foreign to them, right? So they're going to have anti-A antibodies, right?
Mhm.
And so if for some reason they get transfused a type A blood, their
Yeah, it's
antibodies
not gonna
are
work.
going to attack that, right? They're going to have a
Yeah.
response to that.
This diagram is really clear and to the point. I like it.
Awesome. Awesome. This is diagram that helped me understand everything. And then your group AB group is not going to have any antibodies, right?
Mhm.
So these is going to be a universal
Versus.
acceptor, right?
Mhm.
They can
Mhm.
take a B blood or an A blood, right? But they can only donate to blood type AB. They can accept any blood, but they can only donate to AB, right?
Mhm.
Because they have A and B antigens on the surface. They cannot donate to blood types that produce anti-A or anti-B,
Mhm.
right? But they can accept any blood. So if somehow they lose blood, they can take a O, right?
Mhm.
But they can't donate to anyone with a B or type A or AB. I mean, they can take AB. I mean, they can donate to AB.
Mhm.
They can only donate. So just know, donation, AB sticks to themselves.
Mhm.
And then type O, these red blood cells cannot make A or B antigen, right? They don't have an A or a B antigen. So they do not have an A, B, or antigen on the surface of their cell. Individuals with blood type O produce both anti-A and anti-B antibodies, right? Because of both the A antigen and B antigen are foreign to them, right? Because they don't have anything on the surface of their cell, their red blood cells. So A and B is going to be foreign to them, right? So because they produce anti-A and anti-B, they cannot receive red blood cells from anyone except red O, right? And because they don't have A or B antigens, guess what? They can donate to any ABO blood type, right? So it's the opposite of a group,
AB.
right? AB can only donate AB, but can accept any. Type O can donate to any, but can't accept any, but can only take O, right? So you can only take O. And I think that's why it's a little bit difficult sometimes, right? Because there's limited O out there. So that's that. That's why this is important, right? So just know that. And like I said, the way that they'll ask these questions is going to be what blood type can they receive, can they not receive, you know. Maybe they'll even ask questions from like an antibody perspective, right? A type A will have an anti-B, a type B will have an anti-A, AB group will not have any antibodies, group O will have both antibodies, right?
Okay. Yeah, no, that diagram works and helps a lot.
Okay, I will definitely send this PowerPoint to you. So now you have your RH factor group, right? And your RH factor blood group is due to only one surface protein, right? On the red blood cells. And these ones are called D antigen, right? And this antigen is in addition to what we just talked about, right? And since there's only one antigen, right, there are only going to be two RH factor blood types, and they're going to be RH positive and negative, right? And then so when we're talking about the RH system, we're talking about the presence or the absence of D antigen, which is very critical. D antigen is highly immunogenic, right? I put it in red, right? They're highly immunogenic, especially in newborns, right? Your RH positive means that they have the D antigen, right? And then your RH negative means that they lack the D antigen, right? And when I say RH positive has the D antigen, they express it on the surface of their red blood cells, right? And that's going to mean that they do not produce an antibody to D, right?
Okay.
But RH positive individuals have a D antigens. They can only donate red blood cells to other RH positive individuals, right? And RH positive individuals can receive red blood cells from RH positive or negative individuals, right? So they do not produce antibodies. That's why they can, all right? They don't, nothing is going to attack them. They can donate only to RH positives, right? And they can take from both, right? Because they don't have the antibodies. They can take, nothing's going to attack them if they take, right? And then
that's the RH negative.
That's RH positive. They do have the antigen, but don't have the antibodies.
Okay.
Right. And RH negative is just the opposite. They do not express the D antigen, right? But they have the anti-D antibodies. Right. So because the D antigen is foreign to them, right? They have the antibodies, so the D antigen is foreign to them. So RH negative individuals do not have the D antigen specifically, so they can donate red blood cells to RH positive and negative individuals. But RH negative individuals can receive red blood cells only from an RH negative individuals because they have the antibody for D antigen, right? RH negative have the antibodies. RH positive do not have the antibodies.
Okay.
Yeah, so just remember that. And then I also made like a slide on it so you can remember, they express the antigen, they do not have the antibodies, right? They only donate to Rh positive, but can receive both.
Okay.
They do not express antigen for Rh negative. They have the antibodies because D is foreign to B because they don't have the actual antigen, right? So they
Yeah,
can
so they could
donate.
donate to any, they could only receive from one. And it's the opposite with the positive. Okay.
Yes. Okay. All right, cool. Now I'm going to tell you about something really, really cool.
Okay.
This is what we call newborn hemolytic disease, right?
Hmm.
And newborn hemolytic disease, this just means that the red blood cells are dying and they're getting killed off, right? And so hemolytic means dying cells, right? So classically, a newborn hemolytic disease means that they have anti-D antibodies in their blood, right? And it usually happens when the mother is Rh negative, right? Because
Hmm.
the mother has the antibodies, right? And then you have a Rh positive baby that do not have the antibodies. And so what that's saying is, what that's trying to tell you is that the antibodies are crossing the placenta and attacking the baby's red blood cell.
Hmm.
Right, so D negative mothers are capable of developing anti-D antibodies. We said that already, right? So if the father is D positive, baby may also be D positive, or that just means Rh positive, right? So essentially, the way that this works is that the first pregnancy of a mother exposed to to Rh positive RBC at delivery, and then second pregnancy they have the antibody in the mother, so it crosses to the fetus, and the second fetus is going to be is also going to have the D positive hemolysis that will occur in the
That's just with some people, or that's every time you have a second kid.
um so this is for people that have Rh positive or Rh negative blood system.
Okay.
That's just for some people, but you said you were type O, right?
Hmm.
Right.
Yeah.
So with you, it's a little bit different. So I think what happened with you, they call it the same thing, but it has to do more with your O type
Mm.
blood system, because essentially what's happening is like your type A and B are IgMs. Well, the antibodies that really play the big role is you have like all these different antibodies and immunoglobulins in your system, and they
Hmm.
go from like IgM, IgG, IgA, IgEs, right?
Hmm.
And type O blood has IgGs, right? And if you're type O, that means that antibody can cross the placenta and start attacking your baby's red blood cell,
Hmm.
right? And so they can, but it's not as like severe as if you had a Rh, if you were a Rh negative mother versus a Rh positive baby, right?
Hmm.
It would be like it would be less prominent than if you had Rh negative. It will still happen, like the red blood cells will still get killed or they still die, but
Hmm.
it's at like a much less kind of it's still kind of something that you can manage, and it's not as severe as this one, right? Your
Mm.
baby will still come out like, with low bilirubin, and they'll just have to like do the phototherapy and stuff like that. But but that happens to every baby, right? But in your case, they'll probably just stay there longer, a little bit longer. But for patients that have this Rh negative to Rh positive deal, this one is like serious. Like
Hmm.
their baby might be in the ICU. Right?
Wow.
Yeah. But
Yeah,
in
no,
your
that's
case,
crazy.
they probably, it's fairly something that's manageable because type O blood is something, you know, though they do have that IgGs and cross the placenta, so it's not as like severe. It happens, and
More commonly.
yeah, and yeah, it happens more commonly because it's part of the ABO blood system. You know, it's something that they prepare
Hmm.
for. But like for RH negative and positive patients,
It's a whole different
they have a medication they can do with this. Like they have to give them like an injection for
for
when
it.
they have a second baby, so that those antibodies won't attack the child's red blood cell.
Yeah, I know. I remember when I had my first doctor in LA, she explained this to me. Not that I had it, but she was like, "Oh yeah, if you have it, I would have to give you injections." And
Mhm.
yeah, she was really thorough with her lab tests about everything.
Yeah, she has
But
to, because it's like kids can like can for this, for specifically for RH negative positive mother, their kids can get come out with different like malformations and stuff, because these antibodies can like they call it hydrophilus fetalis or whatever
mhm,
for these kids who have a RH negative mother. But I think with
mm.
you is it's you're the type also, she didn't have to give you injection, right?
No, 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 no. She was like, "Oh, I just needed to see what kind of RH you have or whatever."
Yeah.
She wanted to be thorough with everything, even measles. She was like, "I need to see what kind of measles you have, the German measles or whatever."
Yeah,
Yeah, she was very
that's
I
really,
mean, I thought she was just this Beverly Hills fertility specialist I had. And I was like, oh, okay. Then she worked at Cedar Sinai and she was really about her stuff.
yeah, no, it's serious. This stuff is serious, man. Like this newborn hemolytic disease thing.
Hmm.
Yes, that is serious. But the type O one, it's more manageable than this. This one can really, in severe cases, patients can come out with like hydrops fetalis, which just means that they can have with like massive edema in their heart,
Oh, wow.
ascites, things like that. So this one, the type O one is just like a mild case, and can, the at most can probably present with like hemolytic anemia, which just means that their red blood cells is lower than normal. And then when you kill off red blood cells, they release this thing called bilirubin. And so sometimes
That's
babies,
it.
when they're born, they can have yellow skin.
Hmm. Yeah,
Um,
that's how my son was. He was born with jaundice.
Yes, they can have the jaundice, and then they have to do phototherapy in order to like convert that back or manage the red blood cell turnover.
Hmm.
Yep, but it's that other stuff is very normal, but
Yeah,
this
no, that
art
is
stuff,
something.
this is something else. Okay,
Hmm.
now let's talk about erythrocyte development, right? Erythrocyte development is important. This talks more about how our red blood cells kind of grow up, right?
Hmm.
And the structure is pretty much the stem cells is usually from the red bone marrow, which is in the bone. And what happens is that our red blood cells can live up to 120 days, right? And
Hmm.
they have this hormone called erythropoietin, which is abbreviated for EPO. And EPO you can find in the kidney, and it's important for being able to stimulate the growth of red blood cells. So sometimes patients that have kidney damage or chronic kidney disease, they have issues being able to stimulate growth over their red blood cells. So they have, many complications that can happen, including the fact that their red blood cells are gonna not be able to deliver, adequate amount of oxygen to their tissue, right? So they might be a little bit hypoxemic or hypoxemia, right? Hypoxia, right? When they have decreased oxygen delivery to the tissue, things like that. So many things can happen when you have kidney like problems. Ultimately, that is affecting the red blood cells, right? So essentially, what we need to know here is that you have, these stem cells are in the bone marrow. You have EPO or erythropoietin that you can find in the kidney, that the kidney secretes to stimulate the growth of red blood cells in the bone, right? And usually these early young red blood cells are going to be in the bone marrow growing, right? They're going to come from this, what they call the proerythroblasts, right? And it's also the same as pronormoblast, right? Those are the same thing. This is happening in the bone marrow, and then they grow up a little bit more, and turn into erythroblasts, which is the same thing as saying normoblasts, right? And then the most immediate thing that you start to kind of detect in the blood when someone is having, too much red blood cells hemolysis, when someone's red blood cells are dying too fast, they start to have like reticulocytes. So if your reticulocyte is higher than your actual red blood cells, that means that your body is trying to compensate for too much actual red blood cell loss, right? So sometimes what they try to do is they try to detect the ratio of your reticulocyte. If it's higher than, I don't know, maybe 2-3%, if your reticulocyte is in 3%, that means for some reason someone's killing your red blood cells, right? And there's so many different reasons your red blood cells could be dying, right? There's anemia. Maybe you're losing blood because you have a gunshot wound, or something's wrong with the cell membrane of your red blood cells, so the macrophages are coming in to eat it more than they should, right? So the normal reticulocyte count is 1%. So anything above that means that your red blood cells are getting killed more than they should. Or it could also mean that there's just less red blood cells in your circulation. So your reticulocytes are your baby red blood cells. They're literally like, the red blood cells are adults and your reticulocytes are teenagers. So you're basically like sending your teenagers to war before they're adults, right? And you don't want that, because if they're teenagers and your reticulocytes are going to war, they're not able to do what
they
red
need to
blood
be.
cells usually do, right? Red blood cells have these, they have these heme groups that they carry oxygen and all this other stuff. And reticulocytes does not have the same kind of heme group, right? They are involved in hemoglobin synthesis, like heme synthesis, but not specifically in carrying that oxygen. All right, so that's the important about that. Like if you have too much red blood cells, that's called polycythemia vera, right? And sometimes patients that experience that's also dangerous, because that means it will make your blood thicker than usual. And what happens when your blood is thick, right? You're more likely to get blockage somewhere, right, in your blood vessels, right? Low red blood cells mean that you have some type of anemia, right? Right. And so this is what I saw in your PowerPoint. So basically you have this is the pretty much the how your red blood cells can grow. It starts off with, the hematopoietic stem cells in the bone marrow. And then you have your cells can either go into a myeloid stem cell or a lymphoid stem cells, right? Your lymphoids are what we talk about in terms of your white blood cells, right? These are different because this is your B cells or your T cell that's going to be more so involved in responding to viruses, or they can go into your myeloid stem cells, and myeloid stem cells are also involved in the development of red blood cells. And the other cells that's going to be important in bacterial or inflammation management, like your neutrophils, your eosinophils, and your basophils, your monocytes, which are essentially turns into your macrophages, and then your megakaryocytes, which is going to be shedding your platelets. That's important for regulation of bleeding, right? Remember we said in terms of clotting and aggregation and making sure that it blocks off bleeding so you don't bleed out, right? And your
Hmm.
monoblasts or your monocytes that turn into macrophages are macrophages that are important for eating bacterial cell. Though they're not the first responder, they kind of come in a little bit late, but your first responder is going to be your neutrophils, right? Your neutrophils, that's going to be important for bacterial, um, regulation. And then you have your eosinophil and your basophils. They're going to be important for either allergic or parasite regulation, right?
Hmm.
So we'll talk more about that too. So this is some of the stuff that he wants you to focus on, and it's in the PowerPoint, right? In the PowerPoint, he talked a lot more about anemia and the different types of anemia that he might want you to focus on, like sickle cell anemia means that they have abnormal hemoglobin. Why? Because they have this thing where this is something that you learn more in like amino acid, um, different types of like mutations that can happen. And sickle cell anemia is mainly because of like one substitution mutation where a non-polar amino acid becomes polar, right? So,
Hmm.
or no, where a polar becomes non-polar, so it starts to clump and polymerize and stick together instead of doing the opposite. So that's what in sickle anemia, that's why the hemoglobins become abnormal. And then in aplastic anemia, that means your bone marrow is more so very concentrated and directed. That means that your bone marrow is damaged. Some people need bone marrow transplant, right? Because of many different issues. Aplastic anemia means that your bone marrow is not able to develop red blood cells anymore. And so you need a transplant so that you can get more blood cells to grow. But aplastic anemia just means that you don't have that, maybe because of other issues. You know how they have liver cirrhosis, meaning that they have like scar tissue in their
Hmm.
liver. Scar tissue can
Hmm.
happen in your bones too. And when scar tissues exist in the bone marrow, that means that your bone marrow is not able to grow red blood cells, let alone red bloods, period, right? Because we know that most of the blood is like your white blood cell, your eosinophils, neutrophils, all of that are going to come from your blood and your bone marrow, right? So
Hmm.
if your bone marrow is messed up, what does that mean? That means your body
There we go.
can't do red blood cells. They can't
Can
do
get
all these other
nutrients,
cells, so they can have
oxygen.
infections, right? They have issues with probably regulating oxygen and carbon dioxide, right? So many issues can happen. So just know that aplastic anemia is because of that, because of issues directly to where the bone, where um, cell development happens. And then pernicious anemia is more so because there's lack of red blood cell productions because of vitamin B12 deficiency, right?
Hmm.
Okay, so that's important. Okay, so now leukocytes. Remember, we talked about this. We talked about erythropoiesis, or the development of the red blood cells, which is specifically this part, right? All happening in the bone marrow first, right? Erythroblast, erythrocyte, right? It becomes that red blood cells. And then your leukocytes. Your leukocytes are just your platelets, your eosinophils, your basophils, your neutrophils, your macrophage, your T cells, your B cells, your plasma cells, your NK cells. All that is a part of what they call white blood cells, right? And your white blood
Okay.
cells, the normal amount of white blood cells is usually going to be 11,000. And anything that greater than that, that means you have too much. And when there's too much white blood cells that exist in your blood, that means that you have an infection and your blood cells are like trying to respond to that. They're saying, oh no, I need to kill this bacteria. That is what they're saying. And then when you have a lot of white blood cells in your blood, there's other signs that's going to show up that kind of tells you that like there is an infection, right? And that's going to be fever, that's going to be redness, other things, right? When you have an infection, you feel, that your temperature is high, right? Whatever you had that infection, you're probably going to scratch it and it's probably going to become red,
Mm-hmm.
right? And there's going to be cells that's going to be specifically involved in that process that's going to create that redness, and that's going to create or kind of stimulate your body to like, hey, I need you to warm up because I'm fighting an infection, and tell our human host that we are managing an infection.
Mm-hmm.
And then diapedesis just means that when there is an infection, right, your white blood cells need to know how to get to that place, right? Because your blood
Mm-hmm.
cells are one coming from the bone marrow, your T cells and your B cells. Your T cells is going to be, are kind of maturing in your thyroid gland, and then most of them really is going to be in your spleen and your lymph, right? And we'll talk about your lymph nodes and your spleen next time we talk, right? But essentially, because they're kind of congregated in these organs where they like spleen and your lymph nodes, right? They're going to have to travel. Like once there's an infection, they're going to be like, okay, I need to get to the site of infection, right? And how do they do that? They have this thing called diapedesis, where the immune cell is going to move from the bloodstream into the tissue, right?
Mm-hmm.
Does that make sense? Right.
Yeah, that makes
So,
sense.
I mean, this is like all very superficial too, because you're probably in your mind, you're probably like, how in the world are these blood cells getting to the infection site? Are they just going through the bloodstream to the tissues? There's so many different other processes that's going on. Like they have like signals, like, how sometimes we as humans signal and we're like, hey, I'm right here. Cells do the same thing. Literally, they have signal that says, when there is a bacteria, there's different proteins that kind of surround that bacteria, just like they have it on the blood groups for red blood cells. They have specific
Mm-hmm.
protein that's going to surround a bacteria that kind of helps the cells, like neutrophils, say, oh my, kind of
Target in.
helps. Yeah, they start to kind of smell like, oh, he's not supposed to be here. I need to specifically get him and attack him and kill him.
Mm-hmm.
Yes. Okay. Ooh, that was deep, huh? Are you learning a lot? No?
No, I am. I'm absorbing all this material.
All right. So now these are your granulocytes. And you're probably asking, why are these called granulocytes? They're called granulocytes because they literally have these visible spots in their cytoplasm called granules. Like you see these vasopil, and their nucleus is literally covered in purple granules, right? You see these
Mm-hmm.
spots that are just on them, right? And then these neutrophils have this kind of like transparent pink granules that's on their cytoplasm, right? And then the eosinophils, they have this more densely pink in their cytoplasm, right? That is why they're called granules, because they have all of that. But how do you differentiate between all these different types of cells, right? You have neutrophils. Neutrophils, usually you can identify them because they have more than 3 or more lobes, right? Their nucleus
Okay.
is going to be like clumped into like 3 or more, right? 3 or more lobes. Like they're going to be multi-lobe nucleus, right? And their basic function is going to eat small amount of bacterial cells. And basically, anytime there is an infection, your neutrophils are your emergency medical group. These are your EMS people. They're going to be the first cells on site, no matter what happens. And then they're going to call for backup, and they'll call macrophages for backup, right? But neutrophils are going to be your first responders, no matter what happens, right? The way that you figure out what your neutrophils look like is going to be multi-lobed, right? So
Mm-hmm.
now you have your eosinophils, which is going to be like at least 2 to 4%, right? But majority of your granules are going to be 50 to 70% neutrophils. And that makes sense if they're the first responders, right?
Mhm.
Now, if you have eosinophils, there's going to be at least 2 to 4% of them as part of your white blood cell collection. Why is that, right? They're going to be bilobe. When I think about red eosinophils, I think about strawberry, not strawberries, but like, when someone's wearing headphones, I think of like a person with bilobe headphones.
Mhm. Okay, yeah, no, that makes sense.
Literally,
Picturing it that way.
exactly. This is the headphones right here. So they're usually eosinophils are pink and they have headphones on them. And their main goal is to secrete chemicals when there's parasites in the area, right? And then they're also called when there's an allergic response, right? So know that if you have an allergic response, there's a parasite, and if you measure your eosinophils are going to be elevated. And then you have basophils, which are kind of like not as abundant as your eosinophils. They're even less than eosinophils. And eosinophils, their main function is to initiate inflammation. They're going to secrete histamine, and histamine is their main function is inflammation, mainly vasodilation,
Okay.
meaning that they're like separating the cells to let water through them. Does that make sense? I think he'll test you more on like the different functions.
No, this makes sense. Let me see. Yeah, 2 to 4%. Okay.
Okay. Now your A granulocytes are, these are just the other cells that do not contain the visible granules in their cytoplasm. This means that their cytoplasm is going to be clear, right? You have your monocytes, your monocytes turn into your macrophages. And macrophages just starts to like have different names depending on what system you are. In your brain, we talked about it. This is going to be your microglial cells, right? In your liver is going to be your Kuffner cells, right? In your tissue is going to be muscle tissue is going to be your macrophages. In your bone is going to be your osteoclast, right? You're probably like, oh my God, I remember osteoclast. Yes,
Okay.
osteoclast is your macrophage. They have one nucleus, and sometimes, and most, not sometimes, most often they look alike kidney, right? Kidney-shaped nucleus, right? They are found in the blood, but differentiate into macrophages once they're in tissues, right? Like your osteoclast in your bone, your microglia in your brain, your Kuffner cells in your liver, right? So now your macrophages, that's going to be that large, right? Phage. This is going to eat bacteria, right? They're going to phagocytose bacteria. They're going to, if they see a cellular debris, their job is to eat it. They have a long life in the tissue. They're going to differentiate from circulating blood monocytes. Remember, we talked about this at the top, right? Once they go into the tissue, they turn into macrophages. I don't think he's going to be specific in terms of like what activates and what cytokine is involved in terms of like activating macrophages. Just know that macrophages are phagocytosing bacteria, and they're going to go from monocytes and turn into macrophage once they get into tissue. So just know that, I don't know if you've watched Twilight before, Twilight Zone. They can
Yeah.
shape shift once they turn into tissue. And like I said, here you can see that like in the liver, macrophages are Kuffner cells, histiocytes in the connective tissue, Langerhans cells in the skin, microglial cells in the
Oh,
brain,
okay. So macrophages, they could change.
yes, they literally they can like have identity. They turn into a whole different cell once they get to a tissue. They call them
It's
something.
almost like a stem cell.
Yeah, I mean, all of these are initially stem
Eventually, yeah.
cells, and they turn into like this new thing. But macrophages later in stage, once they reach monocytes, can turn into macrophages in tissue.
Okay.
But in the blood, they're monocytes.
Okay.
Okay. And then another part of your granulocytes are going to be what we call lymphocytes, right? Your lymphocytes are
Mhm.
going to be your B cells, your T cells, and your NK cells, right? They're going to be part of like your adaptive immunity, right? Um, right? Uh, and then your B cells are more so going to be involved in humoral immune response. And humoral immune response just means that they have antibodies. Your B cells' job, they until they die, your B cells' job is to produce antibodies, right? When
Mhm.
we have antibodies from getting vaccines, that is your B cells. Your B cells, once they turn into plasma cells, are involved in memory cells. This is the way that your body can remember to have antibodies. For example, you have the COVID vaccine. How does your body remember that I have COVID antibodies? It's because their B cell has turned into memory cells, which means that they store memory to remember that I am a COVID antibody. Does that make sense?
Mhm. That makes sense.
Okay. And then pretty much like your lymphocytes or your T cells or B cells or NK cells, they're more so involved in like viral, viral infection. For example, like someone comes into the emergency room and they're having like, a fever because they have influenza. Some
Mhm.
patients are going to sit there and be like, can you give my son antibody or antibiotic, right? And you're like, no, I can't, because your B cells and your T cells are not going to respond on antibiotics, right?
Mhm.
Right. They're more so involved in viral infection. Does that make sense?
I know that makes sense.
Okay. All right. All right. And then I don't think I talked about it a little bit, but your thrombocytes are just your platelets, and they come from these cells called megakaryocytes. And megakaryocytes are like this big cells, but your platelets literally like they're kind of like snakes. They shed, and the platelets are the little tiny stuff that they shed. So it's
Mhm.
like this picture right here. So they have this megakaryocytes, and then the megakaryocytes is going to shed all this little stuff and turn and have platelets.
Just into platelets. Okay.
Yeah. So just know
Okay.
if they ask you where this platelets derive from, you
They're
say
from mega
megakaryocytes.
and those mega keratinocytes, where do they come from?
They came from they're part of the
Leukocytes?
they're part of this hematopoiesis
Okay. Okay.
myeloid stem cell process, right? This myeloid stem cell can, like I said, can turn into either eryth can either go into the red blood cell development, or they can go into platelet development and turn into megakaryoblast to megakaryocytes, or they can decide to be like, forget that, I don't want to be a red blood cells or a platelet, I want to become a granulocyte, right? I want to become a eosinophil, a basophil, or a neutrophils. Or they can be like, I don't want to be any of those three. I want to be a monocyte or a macrophage later when I grow up, right? Or they can say, I don't want to be any of those. I want to be a lymphoid cells. So they can either turn into a lymphoid stem cell and become B cell, T cell, or NK cell.
Okay. So when people are like let's say you want to donate bone marrow,
Mhm.
are we like stuck with that amount, kind of like ovaries, or we constantly produce these?
Oh, these we constantly produce, depending
Okay.
on like, if your body needs it. Like, for example, if you go onto a mountain, and when you usually go into a mountain, you start to kind of breathe fast because
Yeah.
you lose you're at the
Or
top of the
oxygen
mountain, but that
just
also
ripping through
means
them.
that you're hypoxic, and so that means that your kidney is going to start to uh, is going to start to be like, oh man, like I need more red blood cells so I can deliver more oxygen to my tissues. So your kidney is going to start to secrete a lot of those erythropoietin stuff to make more red blood cells. So you can trigger your red blood cell development if you go up a mountain.
Okay. High altitude. Okay.
And so sometimes people that are like mountain climbers and stuff like that, they can take medication to manage that. Like they can get aceta zolamide to manage the
Red
the
blood cell
trigger.
production.
Yeah,
Oh, mhm.
not just the red blood cell production, yes, as well, yes, but more so like when you go up a mountain, it starts to mess with your um your electrolytes as well. You become more acidic, you know.
Mhm.
So you, and it's mainly because you're like you're exhaling a lot of acid. CO2 is acid in the body. So if you're excreting, taking out a lot of CO2, that means your body's becoming more less, your respiratory rate is becoming less acidic, but your system is becoming acidic, right?
Mm.
So yeah,
Wow.
that's like more complicated. I'm
Yeah.
going to a whole different hole here. Are you? Don't go into the hole I'm going into.
No, no, no. You're good. You're good.
Anyway, but these I really love these, like, because you know, body's so fascinating by like being able to do all this stuff, like literally as we speak, when it comes to COVID and even just COVID vaccine, like these are the cells that are involved in that process. All right, so now we're in the heart.
Hmm.
Let me just run through these real quick because
Okay.
and then we can, you know, end for the day. So
Yeah.
basically, um, the first thing we want to know when we talk about the heart is, where is it?
Yeah.
We want to know, what is the orientation of the heart? What is the location of our heart, right? And so I have this x-ray
Hmm.
right here to kind of give you an idea of that, right? Is in our
Hmm.
thoracic cavity, right? It's going to be wrapped in a serous membranous bag that's going to be called our pericardial sac, right? It's going to be posterior. It is, well, the heart is not posterior, it's obviously very anterior, right? But it's going to be on the left of the sternum between your second and sixth rib, right? And it's kind of
Hmm.
cool, obviously, because like you have this orientation and the heart is sitting kind of, you know, a little, you know, pointing more to your left, right? But it's right there. Um, but it's kind of, you know, the anterior part of your heart is more so the right side of your heart, right? And then your left atrium and your left ventricle is facing the left posterior part of your body, posteriorly. But so when someone gets stabbed in the front of their heart, you're literally probably stabbing the right ventricle,
Hmm.
right? Oh, what happened to that picture that I, oh, and so this is what I wanted to show you. So basically this is like the front of your, this is anterior, right? So you can see
Hmm.
like this is your right ventricle, right? Right.
Hmm.
In the back, you
The
have your
right
left,
to the right ventricle is anterior, more anterior.
more anterior, right? Yes.
Okay.
And then your left atrium is going to be more
Atrium.
posterior. So sometimes if you have heart failure and the fluid backs up and on the left side of the heart, you can compress the esophagus and someone can have issues
Oh, that's how taken.
with swallowing, right?
Hmm.
So this is your left atrium and this is your esophagus right there.
Esophagus. Yeah.
Yeah. So that's kind of cool in terms of the orientation. And then another thing that's kind of important about your heart is that you have like a 3-layer sac surrounding the heart.
Yeah, I remember this one. It's like the
Yes,
epi, right?
yes.
Okay, yeah.
So you have your
My
fibrinous one, which is the toughest layer, right? Right.
just
That's gonna
okay.
be your the very tough part of the pericardium, right? And then you have your
Hmm.
serous pericardium, and your serous pericardium is going to be layered in or separated into your parietal layer, your pericardial cavity, and your visceral layer. And your visceral layer is going to be that layer that's going to be right there at the heart, viscerally covering the actual outer part of your heart. And then you're going to have that pericardial cavity in between, and that pericardial cavity is going to have your fluid, right? And then right after your pericardial cavity is going to be your parietal layer, right? And that's important in the most outermost, the outermost most serious pericardial tissue.
Oh, okay. So there's a lot more of that. I first took like anatomy a long time ago. Um, yeah, I just knew that there was like a pericardium, and yeah. Okay, then so there's
Yeah.
three:
So
pericardium,
you have
the fibrous,
the fibrous one, which is the
parietal.
most outer, right? And then
Mm-hmm.
your serious pericardium is going to be divided into your
More,
pericardial cavity
so
and your
three
capillary.
subcategories.
Yes.
Mm-hmm.
And this is basically like, just kind of a more
In depth.
breakdown of that. Your visceral is going to be right there on your actual heart. Then you have that cavity that's going to have the fluid, right? To kind of
Mm-hmm.
help, lubricate, whenever your heart contracts.
Mm-hmm.
And then you have your parietal layer, which is right on top of that pericardial cavity,
Okay.
right? And so
Mm-hmm.
if you were to have an inflammation, an infection of the pericardial sac, that's called a pericarditis. And then when someone has a heart failure, which can compress the pericardial sac, that is called cardiac tamponade, and more common than what we usually think,
Mm-hmm.
right? So that's the cool part about it. And then you have the histology of the heart, right? And the histology of the heart is pretty much just going to tell you that you have a myocardium and you have an endocardium, right? And this is the pericarditis that I was saying, and then the cardiac tamponade. And then the histology of the heart just shows you that, like, your myocardium is the thickest layer, and you have your endocardium that is going to be the innermost layer, which is thinner, which is usually going to be surrounding your chambers of the heart, right?
Okay.
Does that make sense?
It reminds me of steak. So
Good. I mean, good, not good, maybe. I don't know. And I think we talked about, the cardiac muscle tissues, right? I think the most important thing to
Hmm.
really know here is the structure, like the striated cells, the fact that that's kind of analogous to the skeletal muscle tissue. Then I think what really differentiates the cardiac cells, that it has these intercalated cells that helps communicate those different electrolyte that needs in order to communicate with all the different types of cells, right? To contract. You have your junctions that can do that. And you also have those desmosomes that keep the basement membrane attached to its layer,
Hmm.
right? All right, the heart anatomy. Here we go.
Okay.
Okay, so let's talk about this. Let's get into it. Okay, so you have 4 different chambers in your heart, right? You have your right atrium, your right atrium, your right ventricle, your left atrium, and your left ventricle, right? So
Hmm.
the human heart is going to have that, small chambers, which is your atria. They're going to be divided into your right and left atrium, right? And then they're going to be separated by this thin wall. It's going to be called your interatrial septum, right? And then the ventricles are going to be, you're going to have your right and your left atrium, and they're going to be your largest one. Your ventricle is going to be the hard working part of your heart, right? They're going to be the one
Hmm.
contracting and dealing with that high pressure thing. And they're going to be separated by your interventricular septum, right? Right, which is
Hmm.
right here,
Right there. Hmm.
right? And so your left ventricle is going to be thicker outer wall than your right ventricle. Why? Right? This is because the left ventricle is usually the one that's involved in that pumping the blood into the longer systemic
The.
circulation, right? Um,
Hmm.
and the right part of the heart is more involved in pumping blood into the pulmonary circuit, right? So you have your
Hmm.
deoxygenated blood, right? And that's going to pump into the pulmonary circuit. And then they go into gas exchange, and then they come into the left side via the pulmonary veins, right? And they come back oxygenated to the left atrium, to the left ventricle. And then they're going to be, in order to get to these different places and regulate
Oh,
the
wow.
heart, they're going to have valves, right? That's going to be
Hmm.
involved in this process. You have, in order to remember those valves, you have to try before you buy, right? So you have tricuspid first, in between the right atrium and the right ventricle, and you have your bicuspid or your mitral valve that's going to be between your left atrium and your left ventricle. And then before that blood leaves the right ventricle, it has another valve that's going to
Aortic
go
valve.
into the pulmonary circuit, is going to be your pulmonary valve. And then
Okay.
before that blood leaves the left atrium, you're going to have the aortic semilunar valves. Does that make sense?
Hmm. Hmm. Can you explain it with the mouse?
Oh, with the mouse, I'm sorry.
Yeah.
And then I also have like different pictures too that I'm going to show you. Okay.
Okay.
So here we go. So blood, right, is going to come from
Hmm.
your inferior vena cava and your superior
Okay.
vena cava here, right? And they're going to
Hmm.
drain into your right atrium here, right?
Hmm.
Your right atrium, deoxygenated blood is going to pass through tricuspid valve, right? And then it's going to enter your right ventricle, right? And that pressure is going to build up. And then when that pressure
Push it.
is high enough, then it's going to push and open the pulmonary valve and go into the circulatory circuit. And that circulatory circuit is going to involve your pulmonary artery, right? Your pulmonary artery is going to split and going to your lungs and get
Hmm.
deoxygenated. I mean, it's going to get oxygenated and going to gas exchange. And then once you go into
Hmm.
gas exchange, it's going to come back out and come back into your pulmonary veins,
Veins.
right?
Hmm.
Veins usually carry deoxygenated blood, but not in the heart, right? Your veins here is
Hmm.
going to carry oxygenated blood, right? Your
Hmm.
pulmonary veins is going to go into your left atrium, and they're going to pull into the left atrium. And once that pressure is high enough, it's going to open the mitral valve, right, and drain into the left ventricle. And when that left ventricle's pressure is high enough, it's going to open up the aortic valve right here, right? It's going to mitral valve. It's going to open up the aortic valve, and then it's going to enter your aorta and deliver oxygenated blood to your system, right? Does that make sense?
Yeah, that makes sense.
All right, so now I have all these different
So we
pictures.
have like one that goes up to our head and then the rest
Right. You
around.
have your other um blood system. When I say system, I'm saying that you have your brachiocephalic vein, brachiocephalic artery that's going to go into your neck, right? Your subclavian is going to go to your brain, and then your ascending aorta, descending aorta, all the way down.
Okay.
That's going to supply the rest of the blood, the rest of the body, and I think one thing that I didn't do here is, did I delete it or no? Right, it's right here. But anyway, we said, your aorta going into descending to the aorta right here. And then our descending aorta is going to have different blood arteries that's going to branch. You have I don't think you have to go this in depth, but you do have those different like branches, like your celiac trunk, which is going to have your, superior mesenteric artery, your inferior mesenteric artery, your celiac trunk, and it's going to be involved in like branching your left gastric vein, your left gastric artery, that's going to be involved in supplying blood to your stomach, to your intestine. Your aorta is going to have your renal vein, renal artery that's going to be supplying the kidneys, right? So that aorta is going to essentially descend and branch off to all these different types of arteries that's going to be involved in supplying oxygenated blood to the rest of the system and the body and organs, right?
Hmm.
And then once they deliver all that oxygen, they're going to come back into, their portal vein system, whether that is the portal vein in the
In the liver.
liver, your your vein that's coming back, your arterioles, your capillaries, that's then going to come back and kind of pull into the inferior vena cava and come back to the heart for, and have that deoxygenated, get oxygenated again. And then from the brain, it's going to have that superior vena cava. It's going to drain into the superior vena cava back to the heart. That's going to be involved again in the sending that deoxygenated blood back into the circulatory, back into the pulmonary circuit to go into the heart, into the lungs via the pulmonary artery, right? Via the pulmonary artery, right? Come back to
so
the
you get oxygenated.
Get oxygenated again, right?
Okay.
So I put this at the very end, but just know it's right here too. And we'll talk about all of that here too.
Okay.
But yes, so that was just the very beginning where we kind of talk about, the where the
Gas exchange is coming from.
the gas exchange and the different branches,
branches and ventricles.
right? The descending aorta can go into to supply blood to the rest of the body systemically, right? It starts with the ascending aorta, aortic arch descending. That's going in the descending aorta. You're going to have those different branches, which is he didn't really kind of emphasize in here, which makes sense, right? He just kind of say abdominal aorta. So just know that is like your descending aorta can go into your thoracic or abdominal aorta that will then be involved in the gas delivery, not gas, blood delivery to the other parts of the body systemically.
Okay.
Right. And I think he really, really, really would like you to know these different, the different valves, the try before you buy, tricuspid valve in the right ventricle, mitral valve in the left ventricle, right? And then I think another thing that he wants you to know is that between the mitral valve and the tricuspid valve, you have these muscles called the papillary muscles. And then the strings that are within them are called the chordae tendineae. And these chordae tendineae here they're involved. They're like thin strings that connect the cusp of the valves to the papillary muscles. And the papillary muscles are in the wall of the ventricles. And the wall of the ventricles where they have this papillary muscle, there are small extensions of the ventricle wall and they form these bumps. And these extensions of the cardiac muscles, when they contract during ventricular contractions, to strengthen that, what they do is they strengthen the cusp to prevent them from prolapse or for being pushed the wrong way by the rising pressure, right? So this is what kind of prevent backflow, right? So they don't have different murmurs, right? You have murmurs where they have rigor or stenosis, right? Papillary muscles.
That's what closes the little vents.
Yes, okay. It kind of stabilizes the ventricle, the valves, right?
So do you say chordae tendineae? Okay.
Chordae tendineae is here, the little thin strings. Then the papillary muscles are attached to the chordae tendineae. And what they do is they stabilize those valves so that they don't regurgitate
move and okay.
So they essentially, what you want to know is that they prevent backflow.
Okay.
Okay. All right. Let's see. What else do we need to know here? And then this is just a picture of the aortic valve and then the mitral valve, right? Because they're both in the left ventricle. Right. This is just more pictures. And then another thing that's cool to know is that in the pulmonary valve, you have the coronary opening. In the aortic valve, there's a coronary artery in the aortic valve, and then the coronary sinus is in the essentially in the right atrium. But I'll show you all of that in a second. So we kind of did like the pathway of the blood, right? So essentially, we said that what it does is is coming from where? The systemic
Area
veins,
vein.
right?
Okay.
And that's essentially going to be more CO2, less O2, right? They're going to go into the systemic vein, superior, inferior vena cava. They're going to go into the right atrium, right? And then from the right AV valve, which is your right tricuspid valve, is going to go into the right ventricle. And then your pulmonary semilunar valve, which is pulmonary artery and just pulmonary circuit, going into the pulmonary trunk and arteries, right? That's going to go into the lungs, do gas exchange, come back, pulmonary veins, then drain into the left atrium, right? That's going to then encounter the left AV valve, right? And then that's going to go into, which is your mitral valve. And then it's going to come back into the left ventricle and encounter the aortic semilunar valve. And that's going to go and then push the blood into the aorta and then systemic arteries, right?
And then start the whole process all over again.
Yes.
Mhm.
Right. Okay. So now the coronary artery, the coronary artery system is important. What he wants you to know here is that the coronary circulation is the coronary artery and the coronary veins that carry blood to and from the walls of the heart
Oh,
itself.
okay.
So
Mhm.
what's happening here is that not only does our system and our brain and our, other parts of the body needs blood supply, but our
Mhm.
actual heart and the walls of our heart
Need
need
it too.
oxygen as well. But how do we do that, right? And that's why we have the coronary circulation that's going to be involved in carrying blood to the wall of our heart itself. So the coronary arteries is going to carry oxygen and nutrients to the cell in the wall of the heart itself. And so anything like, I'm sure you've heard of this, like blockage to the coronary artery is going to cause cardiac muscle tissue, arteries or just parts of the wall of the heart to die because they're not getting blood supply, right? Sometimes this is what they essentially call like an MI, right? So essentially what's happening here is the heart drains to coronary sinus in the right atrium. So the coronary sinus is going to be in the right atrium. And so sometimes when there's too much deoxygenated blood, the right atrium can get dilated, right?
Mhm.
So the left coronary artery branches from the left side of the base of the ascending aorta and passes under the pulmonary trunk between the left. So it's going to be right here. So we said base of the ascending aorta right here
Mhm.
and passes under the pulmonary trunk. Well, this is probably not a good picture, but essentially the main point is the left coronary artery is going to be between the left atrium and the left ventricle, right?
Mhm.
So this is the left coronary artery between the left atrium and left ventricle,
Mhm.
right? And the left coronary artery is not externally visible really, but the
No, I see it in my book. I have it right here in my book. It's like somewhere over here. It's like kind of, I don't know if you could see it. It's explaining it.
okay.
Yeah. Has a clearer picture in the book.
Okay, so the aorta is gonna have, coming off the aorta are the two vessels, right? And they're gonna
Mhm.
supply the heart. The left main artery is gonna bifurcate into the LAD and the left circumflex right here,
Mhm.
right? And the LAD, the left anterior descending artery is this is usually what's commonly infracted, right? They're commonly like blocked, right?
Mhm.
um this is usually going to go towards the apex of the heart and going to send branches to support interventricular septum and the anterior regions of both the ventricle, right?
Mhm.
Both the right and left ventricle. So that's just the anterior, supplying the anterior part of the ventricles. So you can see that like if there was a blockage here, it would like most of your heart's muscle will die. Right, and then your left circumflex, right? The left main is going to branch into the LAD and left circumflex, and your left circumflex is going to supply the lateral wall of the ventricle, right?
Mm-hmm.
So it's gonna, what it's gonna do is gonna go around the left side of the heart to the posterior surface of the heart, right? So it has branches that supports the left atrium,
Mm-hmm.
the
Intervention.
posterior region of the left ventricle. Does that make sense?
Mm-hmm. Mm-hmm.
Okay, now your right coronary artery branches from the right side of the base of the ascending aorta and wraps around the right side of the heart, from the anterior to the posterior side of the sulcus. But essentially what you need to know here is that the right coronary is mainly going to supply the right ventricle.
Okay. The right ventricle.
Oops, what did I do? And then your
I feel like I keep seeing this as like a repeat with like almost like what you said. It's like the same kind of like Greek words, but with different organs. So essentially, like almost every organ has like kind of like the same thing going on.
right, you just have
Like
to,
layers on top of layers. You just need to know what location. Okay.
right. Um, sorry. Okay, that's fine. I just got a text from one of my students. Okay.
Oh, I'm sorry. We're kind of over, but
No,
I
it's
think we're
fine.
almost
But
done here.
let's get this done. I have like one more slide left. But
Okay.
yes, descend in the posterior. Right, yes. So just know right coronary, right
It's
ventricle.
for the right ventricle. Mhm.
Right, and then the left main is going to branch into the LAD and left circumflex, right? And your LAD is going to essentially supply pretty much the anterior part of the heart, right? Mostly infracted during a myocardial infarction. Your left circumflex is going to be supplying like the lateral part of your like the side part of the heart, right? um and usually they have this thing called like right dominant, left dominant, but usually 90% of are right dominant, which just means that the posterior descending artery is the branch where the right coronary is going to branch off. Sometimes the the uh the right coronary artery is going to branch off of the left circumflex, but most often the right coronary artery is going to branch from the posterior descending artery or the posterior interventricular artery, right, which
Mhm.
is right here. Okay. All right, so I think the very last part of here, this is just basically talking about like the electrical system.
Mhm. How
Uh,
it's getting powered.
yes, how it is being powered. And basically, what you need to know here is that the kind of the pacemaker of the heart here is going to be your SA node. And your SA node is right here at the kind of like at the superior part of the right ventricle, right? These are going to be your pacemaker cells, and the pacemaker cells are going to spontaneously generate electrical signals. And that's going to determine the heart and the rhythm of the cardiac contractions and the relaxation. So the pacemaker cells are going to be connected to atrial myocytes by gap junctions. Gap junctions are very important, right? And they're going to be the ones that's going to spread the signals directly to them. That's why when we talked about the cardiac muscle tissue, we talked about gap junctions in the
Mhm.
interconnected cells, right? This is how they communicate with each other, mainly because of the electrical signals important
Mhm.
for the contraction in pacing your heart cells, right? And then now you have the internodal tracks or pathway. The internodal path or pathways are just kind of bands of non-contractile tissue of cardiac myocytes that's going to carry electrical signals generated in the SA node directly to the AV node, right? So These are just like non-contractile tissue. And then they'll get to the AV node. And the AV node is just another place. Like this is the next place that the electrical signal is going to get sent to. The electrical signal is going to enter the AV node.
Mhm.
And they're going to be on their way to signal cardiac muscle fibers in the ventricle, right? And that's going to ensure that the atria and the ventricles do not contract at the same time, right? The electrical signals that enter the
Yeah, you don't want to blow up your heart.
right. And so there's like this delay short period, right? So there's always the AV node is usually involved in like, I like to think of the AV node as being patient. The SA node is like contract. I need you to
Impulsive.
happen right now, right? But the AV
Mhm.
node is like,
Let me wait a second.
woosah, relax. I just need to
Mhm.
make sure that the ventricles are on the same page.
Yeah, that's my boyfriend. I'm the essay. Yeah.
And so now what's going to happen is that you're going to have your bundle of his, which is going to be you have your left
Mhm.
bundle branches and or your right bundle branches, right? And your
Okay.
bundle of his or your AV bundle is just a collection of non-contractile myocytes that carry the delayed electrical signals from the AV node across the cardiac skeletons in the bundle branches in the interventricular septum, right? Because that's essentially your interventricular septum, right? So the bundle of his is the only electrical bridge across the cardiac skeleton between the atria and the ventricles, right? So now you have your right and your left bundle branches, right? And the bundle branches are, we said, are non-contractile muscle fibers that split into the right and the left side and carry the electrical signals down the interventricular septums into the apex of the heart, right? Until they reach what we call what? The Purkinje fibers. The Purkinje fibers are right there at the apex of the heart. And they split into like large number of fibers, right? And they transfer the electrical signals from the bundle branches to the ventricular muscles from the apex upward. And that essentially